Continue with the cardiology. There is the acute coronary syndrome questions. There is tons of those questions about STEMI, non-STEMI, and MI type 2. Those questions will be different a little bit than step 2 and step 3. It's more focused about mortality benefits and morbidity benefits, and more about are you able to understand and manage those cases, understand the complications of those cases. Are you going to be a safe physician? So one of the questions, maybe a patient comes with a chest pain. The story sounds like unstable angina. You do the AKG, you see the STT changes, troponin is positive. You admit the patient, then what's next? You need to do serial cardiac enzyme, serial AKG. Then you need to decide what's gonna happen to this patient. Means risk stratify this patient, and within 48 hours, this patient needs to go either for stress test or for the cath lab. You will have a TIMI score, and after that, if TIMI score is more than 2, that means the patients need to go for cardiac cath, or patients on high risk. Who's the patient on high risk? Those patients with troponin keep trending, ECG keep changing, or ST elevation, new ST elevation, and new ST depression is on the monitor on the 12 AKG, recurrent angina, hemodynamically unstable, patient with unstable VTAC, or patient with recurrent VFib, or the patient already has a previous PCI within the last 6 months, or history of bypass, or the patient has an ejection fraction less than 40, and you don't want this non-STEMI to deteriorate his LV function. So then this patient needs to go for the cardiac cath. Otherwise, the patients need to go for stress test to see if there is a new ischemia and if there is a viability, and then if the patient will be improved or will be beneficial to do a PCI. The questions also will be about the medications, the role of beta blocker, especially in the first 24 hours, and how this medication will decrease the size of infarction and help this patient decrease risk for LV dysfunction and hospitalization and recurrent STEMIs, non-STEMIs, and worsening of his LV function. Also, you need to understand before starting the beta blocker the contraindication for the beta blocker. If the patient is already bradycardic or signs of acute decompensated heart failure, then you're not gonna give him a beta blocker. The role of a TPA, if the TPA is indicated at thrombolytics, like the patient is not candidate for a cardiac cath, or the cardiac cath available is more than 3 hours from the center he arrived to, then you decide to give a TPA. Before giving the TPA, it's very important to understand the contraindication. The contraindication will be there on the case, and you have to make sure one of those more common on the board test. A patient with a recent stroke, like within less than 3 months, this is an absolutely contraindication. The other contraindication or controversial contraindication is the use of warfarin. If the patient already on warfarin, you need to test his INR. If the INR less than 2, then maybe yes, he still can take the TPA, but if it's above 2, there is no way, and it's a contraindication. Stress test. There's few questions about what type of test that the patients need to go for. Is it going to be exercise AKG, or is it going to be pharmacological test, or dopamine echo? The rule here, what's his baseline AKG? If baseline AKG is abnormal and the patient can't run, can't walk on a treadmill, then the answer will be pharmacological perfusion tests like Lexiscan, thallium, adenosine. Before giving those medication, the question will be, does the patient has reactive airway disease, or he is taking theophylline or dipyridamole, then he's not a candidate or a good candidate for those pharmacological tests, and the answer will be dobutamine test. Dobutamine echo is looking for the wall motion abnormalities. Mean if the patient already baseline has a wall motion abnormality or a left bundle branch block or has a pacemaker, then it's not gonna be easy to interpret the test. Then dobutamine echo will be not the ideal for them. So for those tests, First question will be the baseline AKG and if the patient can walk, and then will be what's his pace AKG and what's the contraindication for the test. For those tests, you may have some questions about the poor outcome or what's a positive test. A positive test if the patient continues to have a chest pain during the test, if the patient has an ECG changes, ischemic changes, ST depression more than 2 millimeter or ST elevation, early onset prolonged ST depression, ST depression in multiple leads, couplets of VTAC, tachycardia, if the patient has fall or drop in systolic blood pressure, especially early during the exercise, or if the patient failed to achieve the target maximum heart rate, which has to be at least 80% of 222 minus his age. If the patient induced chest pain or the patient anyway has no capacity or METS score less than 5, that means this is a poor outcome and a positive test you need to go for next step. Triple vessel disease, you will have this question of the patient of his 50s or 60s, diabetic, has symptoms of angina, cardiac cath, and they showed like left main lesion or triple vessel disease. And there's the option there like, okay, let's do stenting for the left main and stenting for the RCA and stenting on the left side. No, the answer here usually is should be bypass. This is the ideal for this patient, especially if the patient also has an LV dysfunction. Then again, the answer is bypass, cap it. Of course, before going there, you need to discuss that with the patient, but this is in the guideline. It's bypass for those patients. Um, One of the other questions in this area of acute coronary syndrome, if you're going to start dual antiplatelet and had a patient history of a GI bleed, you need to add PPI. So the answer will be like the patient has this case, came with an MI or non-STEMI, started an dual antiplatelets, statin, beta blocker. Also, he was following, he got the ACE inhibitor. But they mentioned somewhere there in the past medical history, he had history of peptic ulcer disease, or he had a history of a GI bleed that's suspected due to upper GI bleeding. Then what's your next step? They will have like, okay, let's scope him, let's do endoscopy, and after the endoscopy, we'll consider this and that. They will say maybe just give aspirin, don't give Plavix, or give prasugrel only, but there's no aspirin. There's tons of options there. The ideal is to start PPI. And when you're starting PPI, if the patient already on Plavix, the best option for type of PPI usually should be pantoprazole because it's less side effect with the metabolism of the Plavix. One of the medications that also need to be aware of is donepezil that we add for dementia, and the patient came with bradycardia, syncope, lightheadedness. Then if a patient already has a coronary artery disease, you need the beta blocker for the mortality benefit, but your answer will be stop donepezil. They have other options. Maybe they can add the memantine, but not donepezil because of the cholinergic side effect. You will have some question about autoimmune pericarditis, either Dressler or early Dressler, or this is after an MI or after an open heart surgery. Treatment, sometimes, most of the time, we use NSAIDs. You can use some colchicine, other prophylaxis, or even after the surgery. Steroid would be the last resort there. Post PCI still thrombosis. They may have this question about when or the timeline. It's usually after first month. That's more thrombosis than thrombosis. The second major topic, would be the heart failure. Again, it's not step 2, it's not step 3. So the main focus here, you need to have to look thoroughly through this long passage and reading there in the details what's the medications the patient on. Usually there is one medication or two medication is missing, and that's what's the next step. Or titration of those medications and go for the maximum dose. You need to look to their vitals and to see how much they can tolerate. You need to understand the side effect of those medications and when to stop or to hold off on those medications. And we are talking about the GDMTs, especially for heart failure with reduced ejection fraction, HFrEF, including ACE, ARNI is more important than starting Entresto, for example, is more important than starting just lisinopril or losartan. Beta blocker, aldosterone antagonist, and SGLT2 inhibitor. You may have this patient African American, or patient can't tolerate ACE because of recurrent cough, can't tolerate even losartan or ARBs because of the angioedema. Then your next option will be to do mononitrate hydralazine. And again, those medication works by titration to the max. Um, diuretics is only for symptomatic and for volume status adjustment, so that can be added usually always when there is an edema. Digoxin, improving the symptoms, but again, the wide side effect profile is not ideal here, so that's why we use it only for symptomatic at the end and the last resort. It's also reported that it decreases hospitalization. HFpEF with normal LV systolic function. Most important to focus on volume status. If the patient already volume overloaded, you need to give the diuretics. You need to focus on the underlying or associated or trigger disease risks factors like obstructive sleep apnea, hypertension, obesity, diabetes, coronary artery disease, AFib, arrhythmias. You need to control those risk factors to improve his heart failure with preserved ejection fraction. Still, also you can use SGLT2, aldactone, in addition to ACE, ARBs, and beta blocker as tolerated. The use of ivabradine. Ivabradine, one of the medications that we use once the patient already optimized or maximized on GDMT, but he's still tachycardic and he's still sinus rhythm. An ejection fraction is less than 35 symptomatic or less than even 30 asymptomatic. Still, this patient has a room for adding another medication that can reduce the heart rate and does not give a mortality benefit there, but it showed some improvement in hospitalization and symptoms of those patients, which is evaporative. Right side heart failure, one of the questions will be there either for diagnosis of this patient, which is mainly related to a left side heart failure, or a lung disease, either COPD or asthma. But in case of a COPD and asthma, the right side heart failure or the pulmonary pressure, they're usually mild to moderate. If it's already severe, advanced with raised GVD, lower limb edema, severe tricuspid regurg, increase in RV pressure, increased S2, they may ask about the S2, like what's you gonna hear there, or what's the sound there, or what's happening to S2, or EKG changes. There will be a right-sided straining with a right bundle branch proc, RVH, increased atrial size, signs of pulmonary hypertension, or an echo, you will see a paradoxical bulge of the right ventricle to the left ventricle during systole. There's some questions about also Takotsubo or stress cardiomyopathy. They may ask you about the recovery time, which is usually from 8 to 12 weeks. Again, management of heart failure management is not only medication, there is also adding devices. Those devices are ICD and CRTD. What's the indication? The indication you need to read carefully on the passage. If the patient is symptomatic, heart failure, New York classification 2 or 3, and ejection fraction already less than 35, then there is an indication for an ICD. In the same criteria, but the AKG looks wide, especially left bundle branch block or QRS more than 150 seconds, then there is an indication, and even more than 130 seconds, there is an indication for CRTD, because the CRTD will do also the synchronization between the right ventricle and the left ventricle, and this one need to be interpreted with an AKG and echo after implanting the devices to understand and to know and to get the benefit of the device. It's the synchronization. If it's not happening with this AV delay, then the device is not doing the job and it's not going to help with the symptoms and improvement of the LV function. Also, there is other indication, of course, for the ICD. In general, if there is a VTAC, sustained VTACs, recurrent or VFib, or patient or even patient with a class 4 heart failure, the only indication, and you will have this question, it's at least you will have one question about advanced heart failure. If it's already advanced, the question is this patient gonna go for a transplant or no transplant? If he's already on the list for the transplant, then yes, he needs an ICD. If life expectancy is very poor and the patient is not on the transplant list, then there is no indication for ICD. They can use a temporary vest, but there is no indication for ICD. So you need to know also the indication, the contraindication, the side effect or complications after this device-induced arrhythmia, infection, what kind of infection, infective endocarditis, what are you gonna do? If infection happened, you have to remove the device, broad spectrum antibiotics, dual antibiotics. The other question you may have is the time. When is the ideal time for placing an ICD? Let's say this patient who came with an MI and ejection fraction is 20, and he has this wide QRS complex, he had the left bundle branch block, and he's symptomatic heart failure. And he underwent a PCI, and after the PCI, 1 day or 2 days in the CCU, he still has an ejection fraction 20. Is he eligible for ICD? Of course, no, in this case. It's not indicated ICD or CRTD because you need to do the revascularization, optimize medical therapy, and wait for around 3 months after revascularization or 40 days after an MI without revascularization. That's when you can do the ICD or CRTD after MI, post MI. Okay, we're not talking about sustained VTAC or recurrent VFib. That's another indication. Heart failure with amyloidosis. You will have 2 or 3 cases about a patient who came with eye buffiness, maybe signs of edema, nephrotic syndrome. You did an echo and somebody showed like there is an LVH, there is maybe signs of amyloid disease, maybe there's an liver involvement, easy bruisability. So you think, yes, if it's 2 or more organ involved, it could be an amyloid heart or systemic amyloidosis, either AL or AA is primary or secondary. You need to run some few tests, including protein electrophoresis for the serum and the urine, rule out multiple myeloma, MAGUS, and a diagnosis from the genetic. Maybe end up by doing a fat pad biopsy, kidney biopsy to find the diagnosis, and then establish treatment as indicated. Most likely the keys, as you know, is large kidney, because if this patient has a kidney disease, a CKD, usually the kidney size will shrink and be smaller in size. But this patient will have a large kidney on the ultrasound, signs of a heart failure and LVH, cardiomegaly, again, involvement with other disease systems. HELCOM, hypertrophic cardiomyopathy, obstructive cardiomyopathy. By the name, by default, that's what is the disease. Hypertrophy, there is an LVH, there is an outflow obstruction at the aortic route or in the aortic outflow. Maybe there is a SAM motion of the anterior leaflet for the mitral valve. All those are an echo finding, but in the question, they may ask you about the next step. If the question sounds like about the patient's family, it's starting with the family counseling. If the question about the diagnosis, you need an echo, starting with a transthoracic echo to see all those findings on the echo. AKG, an all time AKG is, I will say, like if you have any AKG when you're reading and you're preparing for the test, just Google it. It's easy. You go for Google, or you have this heart life in the fast lane, very good website, and you can type what are you looking for, posterior wall MI, Takotsubo changes, and you see the dagger shape, Q wave, I mean, uh, this patient with a hypertrophic cardiomyopathy, as we mentioned, you may have signs of LVH, severe LVH, and the dagger shaped Q wave in the inferior leads. See, Q wave, Q wave, Q wave, and signs of LVH. If you start counting this, I'm very sure this is more than 5, 10, 20, 25. It's really severe LVH. It's easy to go through, and that's the Takatsubo. Takatsubo can be any STT changes, ST elevation, ST depression, MI. Cardiac cath would be non-obstructive. Posterior wall MI, also you need to, one of the EKGs, don't forget to look at it before going to the test, either by doing the posterior leads, and then you're going to see the ST elevation in 7, 8, and 9, which is here, or even in the 12 lead EKG, and you'll see the deep ST depression in V1 and 2. Okay, let's go back. So again, family counseling is very important in those patients suspected HOOCM. Echo for the diagnosis, LV and AKG interpretations, and so seeing that deep symmetrical T wave inversion V2, 3, 4, 5, 6, which is septolateral, which is the septum area, and that's where you see most likely the LVH is symmetrical T wave inversion, and you will see that dagger shape or Q wave in the inferior leads and 2, 3 AVF. Also, it may involve 1 and AVL. Treatment. Treatment usually, if the patient has an ejection fraction of less than 50, you can add ACE inhibitor, but usually you start with a beta blocker. If can't tolerate beta blocker, it's the calcium channel blocker. You need to know the indication for ICD and the indication for warfarin. Warfarin or DUAX, even anticoagulation, regardless of CHA2DS2-VASc score. Once the patient has an AFib, that's it. They need to be on anticoagulant. ICD indication if patients have high risk for syncope or VTAC, VFib. And who's those patients? If the septum is already more than 30 millimeter or 3 centimeter, he had current attacks of VTAC, or had a family history of somebody with sudden death, then those patients need to have an ICD. One of those examples, there's a patient that female patients came because her brother was recently diagnosed with HOOCM. The patient also, she was fainted twice last month, and she is looking for screening test. If it's at the screening, you can do the genetic counseling. And if the patient is looking for the diagnosis, or the questions looking for the diagnosis, you need to confirm that with an echo. So confirm with an echo, screening with a genetic counseling. You may have also this question, or you need to understand the difference between HOOCM, athletic heart, and hypertensive heart. Hypertrophic cardiomyopathy, the LVH usually is so huge, so big, and it's more than 30 millimeters. In LVH and in athletic heart, usually it's less than 1.5, unlikely to go more than that. In athletic heart, there is no EKG changes, there is no Q wave, and the echo, as we said, is less than 12 millimeters. But in hypertensive heart, you may see some ACG changes like LVH and symmetrical, non-specific STT changes, maybe Q wave, but not the typical ones for HOOCM with the deep T wave in V3 to V6 and the Q wave in the inferior lead. You're not going to see that, but you may see some signs of LVH. And again, echo is very important. You need to do that for all those patients, either athletics or hypertensive, and the septum size will be less than 15 millimeters. So usually it's less than 15 in the hypertensive heart, and in the athletic should be less than 12. Aortic stenosis will be looking almost the same as hypertensive heart, with LVH, septum thickening, this and that, but also you're going to see in the echo the aortic stenosis. And the next topic will be about dizziness.